Kia ora, Bruce Arroll's my name. I'm a Professor of General Practice and Primary Healthcare at the University of Auckland. This talk is about evidence-based medicine, pre-test probabilities and the importance of them, how they relate to diagnostic tests and screening, and also treatment, also the absolute risk or benefit of treatments and numbers needed to treat. So the objectives of this talk are to understand about pre-test probability, which is just another way of saying prevalence in a clinical setting. We need to know the influence and interpretation of results of diagnostic tests in three approximate settings: high prevalence settings, medium prevalence settings, and low prevalence settings. And that can sometimes be due to the location of them. If you're in an intensive care unit, you're probably in a generally high prevalence setting. If you're in primary care, you're in a low prevalence setting, but it depends on the clinical presentation. And then we need to understand the role of likelihood ratios and to understand how absolute risk of a condition relates to the prevalence and influences the effect size of a treatment in terms of the numbers needed to treat. So that's a key take-home point, the relationship of pre-test probability or prevalence to the effectiveness of a diagnostic test or of a treatment. They influence both. So we know pre-test probabilities anyway. If a 4-year-old presents to you with wheezing and coughing, you're going to think the child probably has asthma or bronchiolitis and would be unlikely to have emphysema, because we know emphysema is a condition of older people who've generally been smoking for a long period of time. There are a few exceptions to that, but that would be an example of using a pre-test probability. So it's a high likelihood the child would have asthma or wheeze. So the pre-test probability of a child presenting with wheeze would be about 80% for asthma and less than 1% for emphysema. So there'd have to be extreme reasons why a child of 4 would have emphysema, perhaps some birth trauma or lung trauma when they were younger. So where do we get pre-test probabilities from? Well, we get them from clinical experience. We could get them from senior colleagues. We may be able to get them from the literature. But in fact, often we just take a bit of an educated guess, and that's usually enough, as you will see as we go further with this talk. So why are they important? Well, they form an anchor point for doing likelihood ratios, and they determine the questions we ask the patient. If there's a high likelihood of something, we're going to start asking questions around that until we get enough no answers to go on to something else. They determine what exam and tests we do. So if there's a high pre-test probability of something, then we will examine that organ system and then order appropriate tests. And then there's also understanding the link between the pre-test probabilities, link diagnosis and treatment, and influence both. So when we have a pre-test probability, we have a patient coming in to see us with a condition. They will have some symptoms or occasionally signs, and then we can ascribe a post-test probability. And if that post-test probability is high enough, we can start doing things. For example, with a sore throat, a patient comes in, so we want to know what their symptoms and signs are. And there's this sore throat criteria where we give points for a fever, absence of cough, tender neck glands, swollen purulent tonsils, and age. And if we get a very high score, we might just treat the patient. We'd say they do have a strep throat. We will give it. If they have a low score, we would either wait and see or perhaps swab and test and see what the results were going to show. So a patient comes in with a sore throat. If they've got a temperature, they've got a 10% pre-test probability. I'm making up these figures for the sake of this talk. If they've got pus on their tonsils, the pre-test probability would go up to 15%. If they had a cough, that would drop it down, say, to 11%. If they had tender glands and pus on their tonsils, then we would start getting up to the line at the top, which is a threshold by which we would do different behaviours, either test and treat or treat And if we kept getting negative scores, we would maybe not treat. It would be a rule out. So if the patient had a runny nose and cough, no fever, slightly red pharynx, we would say they probably have a viral condition. So unless they were Maori or Pacific children or high-risk children, we wouldn't treat or swab. So that's another level of risk we take into account. So ethnicity, socioeconomic status, and then on top of that, we add the clinical picture. So we've talked about the pretest as the prevalence in a setting. We've now realized that each question is a diagnostic test in itself. So every time you ask a question, do you have shortness of breath? That's a diagnostic test. Do you cough up purulent sputum? That's a diagnostic test. Do you have chills or fevers? That's a diagnostic test. And each clinical exam is a diagnostic test. So percussing the chest is a clinical exam, is a diagnostic test. Listening to the chest for sounds is a diagnostic test in itself. And each of these questions and clinical exams can have a sensitivity and specificity, just like diagnostic blood tests or X-rays. So why are they important? The purpose of taking a history and doing a physical exam is to increase the pretest probability to a point where we can make a clinical diagnosis and start treatment. Or we can start doing lab and imaging tests and get actionable results. So we will treat the positive and not treat the negative. In the latter instance, we can start doing more expensive and dangerous tests. And I like to say this is the medical equivalent of E equals MC squared. So it applies in whatever setting you're in. So it's something you'll be doing all the time as clinicians. This is a nomogram, so this is a shortcut to getting diagnostic test answers. Some clinicians carry these in their pockets, and it allows us to be portable with our diagnostic reasoning. So this is a rapid strep test. These seem to only apply in America. They don't seem to work so well in New Zealand, but this is a very good rapid strep test. So it's got a likelihood ratio positive of a positive test of 19 and a negative of 0.05. So if we start with a 5% pretest probability, and the test is negative, it pretty well rules it out. So the left-hand line we're starting at 5%, and the right-hand line we're going down to virtually 0%. If we have a positive test, we go up to about 30%. So there's a 30% chance somebody might have a strep throat. In that situation, we might treat if the patient was high risk, Maori or Pacific. If non-Maori, non-Pacific, we might do a throat swab and then treat. But at 30% pretest probability, we would want to take some action. We certainly wouldn't let the patient go. But a negative test, we could let the patient go and not give any treatment. So again, you can think of that flow chart we looked at before, with each question having a nomogram in it. So there's a nomogram going from the sore throat to the 15% tonsillitis, a nomogram going for the absence of cough, a nomogram going from tender glands upwards as we make our way up to getting a diagnosis of streptococcal tonsillitis. So why would we use a nomogram? They're quicker than calculating, and you only need to know the likelihood ratios. You estimate or guess the pretest probability, and then you have the post-test probabilities. And the likelihood ratio allows you to travel, means you can start going to different patients. If they have different pretests, you can apply your nomogram to them. So this is the 2x2 table. So this is how you calculate your sensitivity and specificity. So sensitivity is A over A plus C, and specificity goes the other way up the table, D over D plus B. And for those of you who are mathematically inclined, it shows you how you can calculate the likelihood ratios, which are a function of sensitivity and specificity. Fairly simple mathematics to get the likelihood ratio, as you can see there. So examples of pretest probabilities are 5% of patients presenting to a general practice have a new major depression. 40% of adults inpatients have a major depression, so that's something to think about when you're on the hospital wards. and then a child with a whole bunch of symptoms, 38-degree temperature, all the positive things, will have about a 60% chance of having a streptococcal tonsillitis if they're below 14 years of age. So age is quite important there. So they're examples of common pretest probabilities that we come across in clinical care. So screening is using a diagnostic test in an asymptomatic situation. If a patient comes in with symptoms, that's not a screening situation. So screening is almost always in a low prevalence settings, and that has its own problems. Doing diagnostic tests in high prevalence settings also has its problems, but you need to know which way the problems are going. And this is just showing the sensitivity and specificity table again. And this is a case I saw some years ago. On the 18th of January, a patient who was 85 presented with a 2-week history of being short of breath. She had no fever, very few clinical signs, and I was able to get a chest x-ray on the same day. The chest x-ray showed an enlarged heart, CTR, cardiothoracic ratio of 160/310, which is greater than 50%, but she had no left ventricular failure. A week later, I got a note from the hospital and a chest x-ray which showed that she had mild left ventricular failure. So what is the difference here? And is the first result a false positive or a false negative? Of note, the CTR ratio was over 50%. So that does alert you to the fact this woman may have left ventricular failure, although you can have an enlarged heart but not have left ventricular failure. So the problem for this lady was that her films were under-penetrated. So if you look back on the original films and you knew what the second one showed, you could figure out maybe there was some heart failure there. But of course, we don't live in a retrospective world, we live in a prospective world. And this is a good example of a false negative in a high pretest situation. So at this stage, shortness of breath in an elderly patient, highly likely to be congestive heart failure. Pretest probability is very, very high. And the patient clinically didn't have pneumonia, a pulmonary embolus, or pneumothorax, so she had no other common reason for having heart failure. So just remember that every question in exam finding is a diagnostic test. And this is a very important take-home table. So this is the influence of prevalence of diagnostic tests. So basically, you'll be working in one of 3 settings: low prevalence setting, so that's often screening, medium prevalence, and high prevalence. So diagnostic tests work very well in the medium prevalence. You get a lot of false positives in the low prevalence and false negatives in the high prevalence setting, as we got with our heart failure lady. So the strategy in a low prevalence setting is to do another test or gold standard or delay intervention until safe to do so. In the medium range, we would test the patient, we'd treat positive and don't treat the negative. And in the high prevalence setting, we would either start treatment straight away. We could have started diuretics on that lady and stopped the hospital admission and sorted out the situation later. Or we could have performed a gold standard, which would have been an echo in that lady's situation, but echoes are hard to get acutely. So an example of a low prevalence setting is screening for breast cancer, where for every true cancer, there's 10 false positives. The second medium prevalence situation would be where a patient presents with a lump, and so the clinicians would do a biopsy and treat the positives as if they were cancer, and the negatives would get sent home. And in the high prevalence setting, if a patient perhaps had breast cancer and maybe have metastatic disease, we would probably want to do some sort of scanning, bone scanning or MRI scanning. So in the bottom line there, we can see in low prevalence settings, a negative test is a good rule out, but not a good rule in. Tests work well in a medium prevalence setting, and they're very good at ruling in, but not ruling out. So in our heart failure lady, she was high prevalence, and we got a false negative test on her because it was a high prevalence setting. So hard to know you have to think about what sort of setting you're in, whether you're in a low prevalence, medium prevalence, or high prevalence. And I guess that's one of the clinical skills you develop with clinical experience. So there are common errors in diagnostic tests. We think there are good tests and bad tests. The only good test is a gold standard. Even occasionally that can be wrong. For example, we would probably consider colonoscopy a gold standard for bowel cancer, but occasionally cancers are missed on colonoscopy. Autopsy is the ultimate gold standard, but we don't want to wait for autopsy on every occasion, and we can't. The same test may work well in some prevalent settings and not in others, where there may be more true or false positives and negatives. So the same test may not work. So a chest X-ray will work well in a medium prevalence setting, not so well in a low prevalence setting, and not so well in a high prevalence setting. So you've got to be thinking what's going on underneath. I like to think what's going on in the engine under the bonnet. Common errors in diagnostic tests. People think you need a good sensitivity to rule in a condition. Actually, a good sensitivity is a good rule out when the diagnostic test is negative. This is known as a snout. Sensitivity rules out. An example of this is a BNP, brain natriuretic peptide. When that's negative, it rules out congestive heart failure. And you can see on this 2x2 table, so the two columns are congestive heart failure positive, congestive heart failure negative. You can see that when the BNP is negative, very few people have heart failure. Most people don't have heart failure. So this is known as a snout. The opposite of this is a spin. So a good specificity is needed to rule in a condition. So a high specificity rules in a condition. For example, a high JVP, a jugular venous pressure measured in the neck, rules in congestive heart failure. A high anti-CCP is a good rule in for rheumatoid arthritis. So it's got a high specificity. So this is the congestive heart failure and JVP. As you can see there, if the JVP is positive, it's very unlikely to be congestive heart failure negative. These numbers are sort of made up just to emphasize the point. So this is a spin. A high specificity rules in. So ideally, you like a test to have a high sensitivity and specificity, but in real life, tests either have a high sensitivity or a high specificity. So again, you've got to know a little bit about the validity of the tests you're ordering and the setting room. I show this just for information. This is an ROC curve, which compares sensitivity versus 1 minus specificity. So this is when you're evaluating the effectiveness of a tool. This is BNP against heart failure. And the area under the curve for different cut points tells you how effective it is. And in this case, it's an area under the curve of more than 90%. So that would tell you that a BNP is a pretty good test. The best cut point for a test is up in the top left-hand corner, closest to the corner at the top there where sensitivity is 1. So that's in choosing the best balance cut point. You may want to do a cut point to rule in or rule out, but on average, the best test is up in the top left-hand corner there. You will be seeing this in journals, so I show it to you, not that you need to understand how to do it or to particularly interpret it, but just so you will recognize it. It's called an ROC curve, and it's based on radar science. A receiver operating curve is what it means in radar technology. So we've borrowed some radar technology for clinical medicine. So now I'd like you to do the diagnostic test cases on the handout. So I'll just go on to the second part of this. Okay, so this section is about treatment effect size and numbers needed to treat. So these are measures of effectiveness on treatments and allows us to compare NNTs for different agents can be compared. They are treatment specific, so a numbers needed to treat for antidepressants is not comparable for a numbers needed to treat for cardiovascular treatment, so they're two different conditions. The numbers needed to treat will depend on duration. For acute conditions, it may be over a week. For chronic conditions like blood pressure, it may be over 5 years. We have to think about what the comparison is. Is it against placebo, in which case we might get good numbers needed to treat. If it's against another drug, there will be much bigger numbers to treat. And remember, a bigger number is a less effective treatment. Depends on the outcome measure, whether it's resolution of symptoms or occurrence of a heart attack or death, and the prevalence of the condition in the population tested, so high or low risk. This will become apparent as we go through this section. This is from the 4S secondary prevention trial. The first column there is placebo, and you can see that in over 5 years there were 22% of events. The second column is treatment with simvastatin, 20 to 40 milligrams. So 15.9% of people got a cardiovascular event there. And then we've got the absolute risk reduction, which is a subtraction of those two numbers. And then down below, we've got the number of deaths. So 11.5% in the placebo group and 8.2% in the intervention group. So the number of events is much higher than the deaths. So deaths is a less common event than an event. So an event would be another heart attack, an angina attack, a heart failure attack, an arrhythmia attack. This shows you the absolute risk reduction. So it's 6.7% for major coronary events and 3.3% for deaths. The calculation of the NNTs, it's 1 over the absolute risk reduction. So for coronary events, it's 1 over 6.7%, and that gives us 15. For deaths, it's 30. So 15 people have to be treated with simvastatin for 5 years to prevent another cardiac event. 30 people needed to be treated for 5 years to prevent a death. That's actually pretty good, but this was a high-risk population. This was in a group of people getting secondary prevention that already had an event. So this is a high-risk sort of setting. This is primary prevention of coronary events with a statin. As you can see there, all major coronary events in the placebo group were 6.5%. Compare that to the previous graph or table of 22%. 4.9% of people got an event who got the treatment, and the absolute risk is 1.6%. So much smaller. So the numbers needed to treat here are 1 over 1.6%, which is 62.5. So the numbers needed to treat here are 62.5 in secondary prevention and 15 in primary prevention. So I just want you to think about why for a second, why the figure is higher for primary prevention. That means it's less effective. Remember, a high score means less effective. So this is because the pretest probability or the prevalence events is much higher in secondary prevention. So the 5-year event of event rate in secondary prevention is 22%. The 5-year event rate in primary prevention is 7%. So about almost a threefold difference there. So the take-home message here is that pre- and post-test probabilities are clinically useful. They direct the next question, exam, and test. Every question and examination finding is a diagnostic test, and every one of those things can have a sensitivity or specificity, and you need to have a bit of a feel for that to be a good clinician. Pretest probabilities are clinically useful for diagnosis and treatment in terms of numbers needed to treat. Numbers needed to treat are useful for clinicians. Don't use them for patients. They get very confused about what you're talking about. You need to know how to calculate an NNT, a sensitivity and specificity, and ideally a likelihood ratio. It's not rocket science. Thank you.